Thank you, everyone. So I am Dr. Mascarenhas, and I'm presenting I Have PCOS. Please make sure to pay attention, as I will be having some prizes at the end. All right, so this is our table of contents here. We're going to go through what is PCOS, the normal physiology of ovulation, the hormone cycle, PCOS pathophysiology, symptoms, investigations, diagnosis, types of PCOS, a quick case study, complications, and short management, as I don't want to go into too detail because the next presenter is doing that. I have my little friend here, which is one of our final prizes, so make sure you definitely pay attention, okay? So, polycystic ovarian syndrome. This is a common endocrine disorder, and in fact is the most common one in reproductive females. It is also associated with a metabolic dysfunction and occurs in approximately 10 to 12% of reproductive females. However, this may be underestimated, as it's approximated that 70% of females with PCOS actually don't know about it. It's characterized by a collection of symptoms, hence the term syndrome, because you can have polycystic ovaries without the syndrome and the symptoms. The etiology is not well known. However, there may be a genetic component, as if you have a first-degree relative, you are more likely to have it. And there may be some environmental components as it relates to diet, nutrition, socioeconomic factors, which again may lead back to the diet and nutrition, and geography, mostly because of your sedentary lifestyle and such like that. So, before we get into the PCOS, I want you to understand how we get a follicle first. So, I hope my pointer gets there. As you can see, we start off with your primordial follicle. So everybody is born with 1 to 2 million, I should say females, are born with 1 to 2 million of these primordial follicles, right? By the time you hit puberty, you only have about 300 to 400,000 of those left. So it significantly decreases before you even reach ovulation time period. Then you're going to develop into your primary follicle over there. And as you can see, that little dot in the center is what would become our egg at some point. When you have your hormones on board, you then process into your primary follicle. And you can see on the inside, you're starting to develop your granulosa cells in purple. And then when you get to the secondary follicle there, that's where you have your theca cells. Those are going to produce a number of hormones, and then you reach ovulation, and that's when you have your egg released, right? So each monthly cycle that you have is going to produce approximately 15 to 20 of these follicles, but only one of them becomes a dominant follicle. So as you imagine, we're very special females to have gotten to this point, going from 1 to 2 million to 300,000, down to 1 follicle per month. So it all started with a kiss, right? So the kiss peptine is a neuroprotein that is produced from the KISS1 gene, which was discovered in Hershey, Pennsylvania. And it was named the KISS gene, interestingly enough, because Hershey, Pennsylvania is famous for the Hershey kiss, right? Has nothing to do with the pathophysiology, but Pennsylvania is famous for that, so go Pennsylvania. Then that goes into our hypothalamic pituitary ovarian cycle, starting in our brain with our hypothalamus. That is going to be signaled by the KISS peptine to produce your gonadotropin-releasing hormone, and that goes down to the pituitary gland just below it. In this case, we're only going to be talking about the anterior pituitary, because the other hormones or other diseases we're not interested in today, right? When you have your anterior pituitary stimulated, that's going to produce your FSH and LH, so your follicle-stimulating hormone and your luteinizing hormone. Those then travel through the bloodstream down to the ovaries and produce estradiol and progesterone, which is important for your ovulation cycle. Now, the GnRH it happens in a pulsatile fashion. The life cycle of that is only 2 to 4 minutes, which is difficult to measure, so we tend to measure more the FSH and LH levels, as well as your estradiol and your progesterone. So, a little bit more detailed, this is our cell. So if you remember that follicle, we had your theca cell and your granulosa cell. So as you can see on your left, the theca cell there, you have your LH coming in, and that helps change your LDL cholesterol into what's going to become your progesterones and your androgens, right? So a theca cell is your androgen producer, right? Then that androgen travels into the granulosa cell, which also does a small amount of conditioning from the LH to the progesterone, but that doesn't produce your androgens. What that's doing is that under the influence of FSH, that's going to change your androgen into estrogens, right? Super important. Granulosa cell estrogens. Right, so looking at our hormone cycle here, you can see that starting off right after you've had a period, and we're going to start the cycle over again, we have our LH and FSH at lowerish levels, and that's going to help stimulate the cycle in the hypothalamic pituitary axis, and you're going to have that hormones produced in that follicle. Your estrogen is going to start to increase. So in blue, you can see, oh, sorry, wrong button. In blue there, you can see that we have estrogen increasing, right? When that estrogen increases, you're going to have a positive feedback loop to your hypothalamus to say, produce more, which goes to your anterior pituitary, and that increases your LH and FSH. At that time, because there's a little hormone called inhibin B, that's going to inhibit your FSH a tiny bit, so you actually get more of an LH surge, and that LH surge is responsible for ovulation, so release of that egg from that follicle so that we can hopefully get a baby by the end of it, right? That estradiol is going to continue for a little bit, and that helps increase the likelihood of the sperm transport through the reproductive area so that our egg can have that. But whenever the estrogen goes down, that is going to be changed for progesterone, because the cyst that's left over right there in the ovary is going to produce the progesterone, and that's called your corpus luteum cyst. Your progesterone starts to elevate, and that helps maintain the lining of your uterus so that that egg can then implant in there if it has been fertilized. All right, so we all know our cycle. We've got the LH surge, you've got your estrogen peaking, and then at the end, progesterone is going to maintain that cycle. So what happened to the other follicles? We had 15 to 20 of them. Well, only one follicle wins and becomes the dominant follicle, which ovulates. The other ones go through a process of atresia, where they start to die out, degenerate, and get reabsorbed by the system, and that happens to approximately 98% of your follicles throughout your life cycle. So now that we know that we've produced that, how does that affect us? So you can get ovulation pain. So when that follicle is maturing, that's going to cause a production of those hormones, which can stretch the follicle, and then when that ruptures, you get that achy kind of pain on the one side, whichever ovary is ovulating that month, right? So if you notice right before, in the middle of your cycle, before the period, you can have an achy sensation on one side. That can also cause a little bit more persistence if, when it ruptures, that causes a tiny bit of fluid and bleeding in the area, which can cause a dull, achy, crampy sensation leading up to ovulation. And then what happens after that? Mood swings. Love that for us, right? So right before ovulation, when you have that estrogen spike, you're going to have an association with serotonin, which is your happy hormone, right? We love the happy hormone. That's going to influence us to do the lovely, lovely things that we should be doing for ovulation, right? So we have our happy ovaries, right? However, when you have that decrease in estrogen, you're going to get rid of all of that association with the serotonin, and you can be a little bit more sad, right? We're very emotional during this time of ovulation and post-ovulation. So, going into a little bit more detail as it relates to what happens with your hormones, right? So, typically speaking, 50% of patients with PCOS are going to have obesity, right? When you're obese, you're not able to use that sugar going into your system from the insulin, because most of them will develop some kind of insulin resistance, which is found in about 65 to 80% of those patients. Then you get hyperinsulinemia, because your body says, let's make more insulin so we can get the job done. That hyperinsulinemia is then going to go to the liver and decrease your sex hormone binding globulin, so you have more free androgens, right? Your testosterones are now going up. That insulin also signals to your adrenal glands on your kidneys, over there, cute little kidneys, and that's going to produce more androgens. And those androgens are associated with increase in your visceral fat. So you know that little tummy that we get that's super hard to get rid of? That's your visceral fat. But you can also get fat inputted onto your heart and your liver, and it's just very difficult to get rid of that. So I know this slide's a little bit busy, but we've gone through most of it already, right? So we know that our brain is producing our GnRH, and that's then going to signal the pituitary for our LH, FSH, going down into the blood, to the ovaries. We've got our theca cells producing our androgens. We've got our granulosa cells producing the estrogen. We've got our ovulation happening here, right? But in PCOS, you actually have elevated levels of AMH and inhibin from your follicle, which then go back to the pituitary and go back to the hypothalamus, and you get inhibition of your FSH more, and that increases your relative LH. So you can see 3 times more LH here, and then that's going to go down. And so instead of having more follicle stimulation and maturation of your follicles, you just end up producing more follicles, and then they don't mature, and you end up with multiple immature follicles, right? So, what did we say? We have our insulin. That's going to be in high levels. We've got our testosterone in high levels. The inhibin from your follicle, high levels. That's going to produce more LH from your anterior pituitary. And then you end up with more follicles, more AMH. So on an ultrasound, you can see multiple immature follicles. Typically in PCOS, you'll have 20 or more follicles. So symptom-wise, what does all of this do to us? So you can see we've got androgens, and that works on your scalp, so you get reduced hair there, and can be associated with female pattern baldness. Conversely, when that works on other areas of the body through the same hormone, unfortunately, you can get hair to the chin, chest, abdomen, and sometimes the back. That's signs of hyperandrostenism, right? Then you can have a decrease in your ovulation cycle, so reduced menses. You can have overall elevated insulin, testosterone. You can have, sorry, I'm difficult reading, acne, and then overall, we're just very, very emotional, right? So, investigations. What are we doing for this? Is it important, right? First of all, if you're not having a period, first thing we got to do is do a pregnancy test. Number 1 reason for a female not having her period, right? Then you're going to check your blood tests. Is your testosterone elevated? DHEAS is from the adrenal glands, so that type of testosterone, is that elevated? Your sex hormone binding globulin, LH, FSH. Prolactin is another hormone that can cause anovulation, so no periods, so it's important to rule that out. Is your AMH elevated? Progesterone. Other causes need to be ruled out as well, so is your thyroid function working? Is your insulin level elevated? Are you having elevated insulin that leads to diabetes? So is your HbA1c elevated? Is your fasting lipids elevated? All right, and then, pointer. We've got our ultrasound findings. Everybody knows about the ultrasound. Do we have polycystic ovaries, right? And also important to see on the ultrasound is if you're not having regular menses, is there thickening of your lining, right? Because you can have consistent estrogen, which leads to buildup of that lining and increases your risk for cancer of the uterus. Then we need to know, how do we categorize that? It's primarily a diagnosis of exclusion, so we've ruled out everything else. And we're going to use the Rotterdam criteria, and that's a preferred tool because you can get at least 2 to 3 of those criteria met to meet the diagnosis for PCOS. Whereas historically, we used to use the National Institute of Health from the 1990s and the Androgen Excess Society from 2008, which needed 3 criteria, right? But as we know, some things are not always perfect. We may not meet the whole criteria. So our Rotterdam criteria, you can have irregular periods or anovulation, and that typically tends to occur just around menarche. Then you can have polycystic ovaries on ultrasound, but be aware, just because you have polycystic ovaries does not mean you have the syndrome. And you're going to have 20 or more follicles at that time. It's not going to happen on every cycle, so if you don't have it this month, it's possible you can have it another month because those follicles are building up every time you go through that cycle. And then lastly, you can have clinical or biochemical signs of excess androgen, right? So are you having the blood test elevated? Are you having those symptoms of the acne in the hair? So 4 types of PCOS. Type A is your classic PCOS. So are you having elevated androgens and the polycystic ovaries and irregular periods? You've met all 3, right? Then you can have type B, which is your non-PCOS. So you're having the other 2, just not having the polycystic ovaries. Type C is your ovulatory PCOS. So you're still having regular periods, but you have the polycystic ovaries and you have the hyperandrogenism. Then type D is the non-hyperandrogenism, so you're just not having those elevated levels, but you've got the polycystic ovaries and you've got the irregular menses. Quick case study. So I had a patient come in, we'll call her Jane Smith today, 33-year-old female. She was obese at a BMI of 42, had never had kids, and she complained of having no periods for over a year. She had regular-ish menses until about age 22, then began missing months. She had thick hairs to the chin, chest, and abdomen, and when we did an ultrasound, she had polycystic ovaries, all right? That's your classic. She's met all 3 of the Rotterdam criteria. So her biochemical panel, you can see she had elevated testosterone, elevated LH, elevated AMH, elevated inhibin B, elevated insulin. She's met all 5 of those hormone elevations that can be associated with PCOS. Complications now. So, like I said before, if you're not ovulating properly, you're at higher risk for that buildup of the lining of your uterus and higher risk for cancer. You can have cardiovascular risk. So, because you're not having proper hormone production, your liver is producing elevated lipids. You can have increased insulin resistance, elevated HbA1c, which puts you at risk for diabetes type 2, dyslipidemia, coronary heart disease, and stroke. There's also the psychological risk. Depression, anxiety, our mood swings are not regular like they would be in, unfortunately, females who are obviously ovulating, but it's worse when you're not ovulating properly. Your hormones are doing all sorts of things. You can have pregnancy risk, so you're at higher risk for developing gestational diabetes, pregnancy-induced hypertension, preeclampsia, and miscarriage. So management, light touch on that. So this is going to be symptomatic treatment, right? Do we want to treat the hairs? Do we want to treat the fact that you're not ovulating well? And then it's going to be goal-oriented. Are we treating you so that we can improve your fertility, or treating you so that we can have just control of those periods? It starts with lifestyle modification. So diet and exercise is a big part. We want to reduce your obesity, improve your insulin usage. Weight loss is a big thing. Again, we want to interrupt that cycle. Cosmetic treatments. Are there things we can do? So those are listed there, but I'm being told we need to hurry up. Then you have management with oral contraceptives, Mirena IUCD, metformin, myo-inositol can improve your insulin sensitivity. Do we want to use anti-androgens if you're having elevated androgens or symptoms of that? And then infertility medications. Surgery is not really indicated because if you have multiple cysts, not usually an issue, they tend to reabsorb or build on themselves and then burst. But if you have a big cyst and it's not going away and starting to cause you symptoms, then we might say, okay, maybe surgery is indicated. All right, here's our quiz questions. So I'm going to ask my lovely ladies at the back to come with up my prizes. So I've got a couple pens with sperm and egg in them. I've got a pin and a pouch that says don't overreact. And then I've got a couple notepads that say really funny things because we're very emotional women. And then, of course, my ovary. So question 1, in which US state was the KISS gene discovered? Hold on, I saw a hand at the back in the blue spotted shirt there. Hershey, Pennsylvania, all right, she got it. Which part of the pituitary is included in the HPO axis? Is it anterior pituitary or posterior? Over there in black? Say it louder. Anterior, great. What are the 2 hormones produced by the anterior pituitary gland? Over there in green. Lovely, over there. What are the 2 hormones produced by the mature follicle? All right. Come on, over there. Sorry? I can't hear. Yes, estrogen and progesterone. All right, which hormone is primarily responsible for your mood swings? Over there in red. Serotonin, which is associated with your estrogen. Great. Name 2 symptoms of PCOS. Yeah. Mood swings. Weight loss. Weight loss? All right, go for it. Anybody else? Over there? Acne and fatigue, great. Anyone? In white over there? Okay, great. 2 more people? Yes. 1 more person. Great. All right, so last one over there. So what are the 3 conditions met in the Rotterdam criteria? Great. All right, name a condition associated with PCOS. So what is one of those complications, those cardiovascular risks? Diabetes, great. All right, difficult question. This is for the prize. Got 2 of them. All right, which follicular cell type produces the estrogen? Right? Remember? Well, you can't win 2. Over there? All right, great. No. She's got that one. Okay. And then last one, which 5 hormones can be found to be elevated in PCOS? See my colors? I said them many times. All right? Not the FSH. All right. right, hand in the back behind you. Let's go. We got to name all 5. Okay, great. All right, so she can have this one there. Thank you so much.
Thank you, Dr. Mascarenhas, for that engaging presentation, exciting quiz session. So I'm not sure that we actually need a Q&A, but we have 5 minutes for questions. But before we get to that, I would like to take a couple minutes to just welcome a few of our other special guests that have arrived. I'm told that the Honorable Andre Ebanks, Premier and Minister for Financial Services and Commerce, is here with us. Please give him a round of applause. And Mrs. Julie Hunter, Parliamentary Secretary. Mrs. Felicia McLean, Chief Nursing Officer. Mrs. Exie Tomlinson-Panton, Deputy Chief Officer. And Mrs. Bobeth O'Garrow, Deputy Chief Officer. Thank you for being here with us today. So we'll take 2 minutes for questions. Does anybody have any questions for Dr. Mascarenhas? Over that side, somebody with a mic.
Hi, good morning. Love the presentation. The cyclic nature of feminine hormones, though, makes me wonder, is there an optimal time to test for those 5 hormones that we expect to be elevated in PCOS?
So if they've met the Rotterdam criteria, that gives you high suspicion of it, then that's when we would test for it. So most of my patients that come in will say, oh, doc, I haven't had my period for this many months. You know, I think I might have PCOS because everybody's done their research already. And that's when I would test to make sure that first we're ruling out those other causes of lack of periods, and then I would do those hormones. Some of them are done at specific times of the cycle, which can be difficult if you're not having regular cycles, and we don't typically want them to be on a hormone method at the time that we test for the hormones. Okay. Anything else? Yeah? Question here in the center?
When treating PCOS, have you noticed any improvement in symptoms using non-traditional treatment like acupuncture?
I can't say I have because I haven't done non-traditional yet. So I've only been in obs and gynae for about 2 years so far, and traditional medicine is more what I do, except for maybe diet and exercise. I have seen at least 2 patients so far that say they changed their diet, they lost 5, 10, 20 pounds, and in fact, one of them lost 20 pounds and ended up pregnant the next time I saw her.
Okay, thank you once again, Dr. Mascarenhas, for that lovely presentation. As a token of our appreciation, we'd like to present you with this small gift.